Respected President, Secretary, senior colleagues, Dr. Alex Franklin, sir, and dear friends. I'm here to welcome you all to this second clinical club of our prestigious IMA AMS Trivandrum chapter. And this is the first one in 2023. The topic is osteoporosis and you. A very interesting topic, and I'm pretty sure that this is going to be a very useful session for every one of us. First of all, I welcome our IMA Trivandrum President, Dr. G.S. Vijayakrishnan. He is attending this in spite of his busy schedule, organizing the state meet of KGMOA as outgoing president. Welcome, Dr. Vijayakrishnan. And Dr. Altaf,
thank you.
Our vibrant secretary of IMA Trivandrum branch is joined. He could not attend our first one because he was busy attending the overseas chapter of IMA Trivandrum branch. He's a man of brilliant ideas, and hearty welcome, Dr. Altaf.
Thank you, sir.
Dr. Anand Marthandapillai is a convener of our AMS chapter. He's a very famous interventional cardiologist. He's a part of our AMS family. I don't think I need to welcome him. And I welcome our senior member, Dr. Alex Franklin, sir. He always encourages a lot. Thank you, sir. The faculty is Dr. Shah Navas, sir. He was the professor of orthopaedics in Trivandrum Medical College, and right now he is in SUT Medical College, Vattapara. He served IMA Trivandrum branch as secretary and president, and Kerala Government Medical College Teachers Association as president, and IMA Research Cell as a convener. He's at present the president of Retired Government Medical College Teachers. When I requested him to participate in our AMS Clinical Club, he agreed with a lot of enthusiasm without any fuss, selected an excellent topic, and sir, you really encouraged a lot. Thank you, sir. Thank you so much, sir. I'm really thrilled to welcome you, sir. And I welcome all the participants. And I request you to attend all our academic sessions. We are going to organize a series of academic sessions, very good academic sessions, I must say. Please attend and encourage us. I request Dr. G.S. Vijayakrishnan, the respected president of IMA Trivandrum branch, to say a few words.
Thank you, sir. Respected Secretary Dr. Altaf, past President Alex Franklin, sir, AMS Chairperson, Chairman Dr. Pradeep Kadangur, sir, Convener Dr. Anand, and respected seniors and dear friends. And respected AMS Chairman of State, Dr. R.C. Srikumar, sir. IMA Trivandrum പുതിയ രീതിയിലേക്ക് മുന്നേറിക്കൊണ്ടിരിക്കുകയാണ്. നമ്മുടെ ഏറ്റവും വലിയ അക്കാഡമിക് ബ്രാഞ്ചുകളായ AMS CGPയും ഒരുപാട് വെറൈറ്റി ആയിട്ട് നമ്മുടെ പ്രൊഫഷണൽ എക്സലൻസ് എങ്ങനെ മുമ്പോട്ട് കൊണ്ടുപോകാൻ സാധിക്കും എന്ന രീതിയിൽ പ്രോഗ്രാം ചെയ്ത് മുമ്പോട്ട് കൊണ്ടുപോയിക്കൊണ്ടിരിക്കുന്നു. ഒരു പ്രൊഫഷണൽ ഓർഗനൈസേഷൻ എന്ന രീതിയിൽ
Hello. Hello.
ഇന്നലെ നമ്മുടെ CGPയുടെ കേൾക്കാവോ സാറേ? ഹലോ.
കേൾക്കാം പറഞ്ഞു.
ഇന്നലെ നമ്മുടെ CGPയുടെ ഒരു മന്ത്ലി ടോക്ക് ഉണ്ടായിരുന്നു. ഡയബറ്റീസ് അപ്ഡേറ്റിനെ കുറിച്ച് ഡോക്ടർ ശ്രീതങ്കുമാർ സാറിന്റെ ഒരു എക്സലൻസ് CME നമ്മൾ ബ്രാഞ്ചോടെ വെച്ച് സംഘടിപ്പിച്ചിരുന്നു. നമ്മുടെ എല്ലാ മീറ്റിങ്ങുകളും ഹൈബ്രിഡ് മോഡിലേക്ക് ഓവർസീസ് ഉള്ള നമ്മുടെ മെമ്പേഴ്സും കാണത്തക്ക രീതിയിൽ ഹൈബ്രിഡ് മോഡിലേക്ക് നമ്മൾ മാറ്റിക്കൊണ്ടിരിക്കുന്നു. ഇന്നലെയും നമുക്ക് ആ രീതിയിൽ പുറത്തുള്ള UAE ഉൾപ്പെടെ രാജ്യങ്ങളിൽ വർക്ക് ചെയ്യുന്ന നമ്മുടെ മെമ്പേഴ്സിനും പാർട്ടിസിപ്പേറ്റ് ചെയ്യാൻ പറ്റുന്ന രീതിയിലാണ് നമ്മളിപ്പം കാര്യങ്ങൾ പ്ലാൻ ചെയ്ത് മുമ്പോട്ട് പോയിക്കൊണ്ടിരിക്കുന്നത്. നാഷണൽ IMA മീറ്റും IMA ട്രിവാൻഡ്രം ഒരുപാട് വർഷങ്ങൾക്ക് ശേഷം ഹോസ്റ്റ് ചെയ്യാൻ പോകുന്നു. 2023 ഡിസംബറിലാണ് ആ മീറ്റ് വരുന്നത്. അവിടെയും നമുക്ക് അക്കാഡമിക്കായിട്ടും പ്രൊഫഷണലായിട്ടും ഒരുപാട് കാര്യം ഡിസ്കസ് ചെയ്യാനുണ്ട്. അതിൻ്റെ ഓർഗനൈസിംഗ് കമ്മിറ്റി ഫോർമേഷൻ ഉൾപ്പെടെയുള്ള കാര്യങ്ങൾ നമ്മൾ വരും ദിവസങ്ങളിൽ ഡിസ്കസ് ചെയ്ത് മുമ്പോട്ട് പോവുകയാണ്. IMA ട്രിവാൻഡ്രം വേറെ രീതിയിൽ, വേറെ തലത്തിൽ മെമ്പേഴ്സിനെ എങ്ങനെ എക്വിപ്പ് ചെയ്യാൻ പറ്റും എന്ന രീതിയിൽ മുമ്പോട്ട് പോയിക്കൊണ്ടിരിക്കുന്ന സാഹചര്യത്തിൽ AMS നല്ല രീതിയിൽ ഡോക്ടർ പ്രദീപ് കൊടങ്ങൂർ സാറിന്റെ നേതൃത്വത്തിൽ ഡോക്ടർ ആനന്ദ് മാർത്താണ്ഡപിള്ളയും ചേർന്നുകൊണ്ട് നമുക്കെല്ലാം പ്രയോജനം ചെയ്യുന്ന രീതിയിൽ കാര്യങ്ങൾ മുമ്പോട്ട് പോയിക്കൊണ്ടിരിക്കുന്നു. ഇന്ന് നമുക്ക് ഓസ്റ്റിയോപോറോസിസ് ആൻഡ് EU എന്നൊരു ടോപ്പിക്കിനെ കുറിച്ചാണ് അവിടെ ക്ലിനിക്കൽ ക്ലബ്ബ് നമ്മളോട് സംഘടിപ്പിച്ചിരിക്കുന്നത്. ഷാ നവാസ് സാർ തന്നെയാണ് നമ്മുടെ ഫാക്കൽറ്റി. എല്ലാവിധ ആശംസകളും നേരുന്നു. പ്രോഗ്രാം നല്ല നടക്കട്ടെ. കൂടുതൽ സംസാരിച്ച് ദീർഘിപ്പിക്കുന്നില്ല. വരും ദിവസങ്ങളിലും വരും മാസങ്ങളിലും നമുക്ക് നല്ല രീതിയിൽ പ്രോഗ്രാം നടത്തി മുമ്പോട്ട് പോകാം. എല്ലാവരുടെയും സഹകരണം പ്രതീക്ഷിക്കുന്നു. താങ്ക് യു വെരി മച്ച്.
And I welcome, I request Dr. Altaf to say a few words.
Thank you, sir. Respected IMA Trivandrum President, Dr. G.S. Vijayakrishnan, respected senior leaders, Dr. Pradeep Kodangur sir, and all other dignitaries and my dear colleagues and friends. Actually, Dr. Vijayakrishnan, IMA Trivandrum President, സൂചിപ്പിച്ചതുപോലെ നമ്മുടെ ഒരു ഏറ്റവും പ്രസ്റ്റീജിയസ് ആയിട്ടുള്ള ഒരു വിങ് ആയി മാറിയിരിക്കും ഇപ്പം IMA AMS ട്രിവാൻഡ്രം. ഓരോ മാസവും തന്നെ നമുക്കിപ്പം 4-5 പ്രോഗ്രാംസ്, അതും വളരെ യൂസ്ഫുൾ ആയിട്ടുള്ള ഏറ്റവും റെലവൻറ്റ് ടോപ്പിക്സ്. ഇപ്പൊ തന്നെ ഇന്നത്തെ ടോപ്പിക് തന്നെ നമുക്കിപ്പോൾ അറിയാം, കേരളത്തിന്റെ കോണ്ടെക്സ്റ്റിൽ നമുക്കിപ്പം ഒരു വശത്ത് മോർട്ടാലിറ്റി കുറഞ്ഞുകൊണ്ടിരിക്കുന്നു, അറ്റ് ദ സെയിം ടൈം മോർബിഡിറ്റി, ഇന്ത്യയിൽ തന്നെ ഏറ്റവും ഹയസ്റ്റ് മോർബിഡിറ്റി റിപ്പോർട്ട് ചെയ്യുന്ന സ്റ്റേറ്റ് ആണ് കേരളം. അതിന്റെ ഒരു റീസൺ നമ്മുടെ ലോഞ്ചിവിറ്റി കൂടുന്നു, ഏജ്ഡ് പോപ്പുലേഷന്റെ പ്രപ്പോർഷൻ കൂടുന്നു. ഇപ്പം റൈറ്റ് നൗ ഇറ്റ് ഈസ് ഓൾമോസ്റ്റ് 16%. In the near future, it may become 20%. That means 1/5 population will become a 60+ age group. Naturally, അവരുടെ aging related ആയിട്ടുള്ള problems, health problems, അതിന്റെ morbidity on side. At the other side, lifestyle diseases, ബാക്കിയുള്ള എല്ലാം ഈ യങ് പോപ്പുലേഷനിൽ പോലും ഡയബറ്റിക്, ഹൈപ്പർടെൻസീവ് ആയിട്ട് അങ്ങനെ വലിയൊരു മേജർ ചങ്ക് ഓഫ് പോപ്പുലേഷൻ become ill. അപ്പൊ നമുക്ക് മോർട്ടാലിറ്റി കുറഞ്ഞതുകൊണ്ട് മാത്രം ആയില്ല, മോർബിഡിറ്റി ഡ്രാസ്റ്റിക് ആയിട്ട് സിഗ്നിഫിക്കന്റ് ആയിട്ട് നമുക്ക് കുറയ്ക്കാൻ പറ്റണം. അത് കുറയ്ക്കുന്നതിന്റെ കാര്യം വരുമ്പോൾ ഒരു പ്രശ്നം, ഇപ്പൊ തന്നെ ഇന്നത്തെ ടോപ്പിക് തന്നെ ശരിക്കും കഴിഞ്ഞ നമ്മളൊക്കെ ഇപ്പൊ പഠിക്കുന്ന കാലത്തുള്ള പോലെയുള്ള ഹെൽത്ത് പ്രോബ്ലംസ് സൊസൈറ്റി ഫേസ് ചെയ്തുകൊണ്ടിരിക്കുന്നു. ഈ പറഞ്ഞ ഏജ് പോപ്പുലേഷൻ കൂടുന്നു, അതിനനുസരിച്ച് അവരുടെ ഹെൽത്ത് പ്രോബ്ലംസ് അഡ്രസ് ചെയ്യാൻ വേണ്ടിയിട്ട് നമുക്ക് കൂടുതൽ റീസെന്റ് എവിഡൻസസും അതിനെക്കുറിച്ചുള്ള ട്രെയിനിങ്ങും ഒക്കെ ആവശ്യമുണ്ട്. അപ്പം തീർച്ചയായിട്ടും ഒരു മെഡിക്കൽ കോളേജ് ഫാക്കൽറ്റിയേക്കാൾ വളരെ ഞാൻ പലപ്പോഴും സൂചിപ്പിക്കാറുള്ള പ്രദീപ് കൊടങ്ങൂർ സാർ ഏറ്റവും റിലവൻ്റ് ആയിട്ടുള്ള ടോപ്പിക്കുകൾ ചൂസ് ചെയ്ത് മുന്നോട്ട് വയ്ക്കാൻ, അതുപോലെ അതുകൊണ്ടാണ് ഇത്രയും പാർട്ടിസിപ്പേഷൻ ഉണ്ടാകുന്നത്. തീർച്ചയായിട്ടും സാറിനെ ഞാൻ പ്രത്യേകിച്ച് അഭിനന്ദിക്കുന്നു, ഇതിന് വലിയ നല്ലൊരു ലീഡർഷിപ്പ് കൊടുക്കുന്നത്. IMA ട്രിവാൻഡ്രത്തിന്റെ ഏറ്റവും ഇനി അടുത്ത ഒരു 1 year കഴിയുമ്പോൾ ഞങ്ങൾക്ക് ഷോക്കേസ് ചെയ്യാൻ പറ്റുന്ന ഏറ്റവും വലിയൊരു അച്ചീവ്മെന്റ് എന്ന് പറയുന്നത് AMSന്റെ ആക്ടിവിറ്റീസ് ആയിരിക്കുമെന്ന് എനിക്ക് ഉറപ്പുണ്ട് ഇപ്പോഴത്തെ നിലയ്ക്ക് തന്നെ. തീർച്ചയായിട്ടും സാറിനെ അഭിനന്ദിക്കുന്നു. അതുപോലെ എല്ലാവർക്കും ഇനിയുള്ള ദിവസങ്ങളിലും വരാൻ പോകുന്ന AMSന്റെ പ്രോഗ്രാംസ് അത് കഴിയുന്നതും അറ്റൻഡ് ചെയ്യാൻ ശ്രമിക്കുക. നമുക്ക് ഒരുപാട് കാര്യങ്ങൾ അപ്ഡേറ്റ് ചെയ്യാനുണ്ട്. നമ്മൾ പഠിച്ച 10, 20, 30 വർഷം മുമ്പ് പഠിച്ച കാര്യങ്ങളോ അല്ല ശരിക്കും പറഞ്ഞാൽ ഇന്ന് സമൂഹത്തിലെ ഹെൽത്ത് പ്രോബ്ലംസ്. അപ്പം അതിനെ അഡ്രസ് ചെയ്യാൻ പറ്റുന്ന രീതിയിൽ നമ്മുടെ മെഡിക്കൽ കമ്മ്യൂണിറ്റി, മെഡിക്കൽ ഫ്രട്ടേണിറ്റി എക്വിപ്പ് ചെയ്യുക എന്നുള്ളതാണ് AMSന്റെ ഏറ്റവും വലിയ ദൗത്യം. ആ ദൗത്യം ഏറ്റെടുത്ത പ്രദീപ് കൊടങ്ങൂർ സാറിനെയും അതുപോലെ ഡോക്ടർ ആനന്ദ് മാർത്താണ്ഡപിള്ളയും അതുപോലെ മറ്റ് ടീം മെമ്പേഴ്സും അതുപോലെ എല്ലാവരും ഇതിൽ പാർട്ടിസിപ്പേറ്റ് ചെയ്യുന്ന എല്ലാവരും AMS മെമ്പേഴ്സിനെയും എല്ലാവരെയും ഞാൻ അഭിനന്ദിക്കുന്നു. ആൻഡ് താങ്ക് യു. ആൻഡ് നല്ല രീതിയിൽ ഇന്നത്തെ പരിപാടി നടക്കട്ടെ എന്ന് ആശംസിക്കുന്നു. താങ്ക് യു.
Over to you, Dr. Shah Navas, sir.
Thank you, Dr. Pradeep, sir. I am greatly honored as a member of the IMA Trivandrum as well as the faculty of your esteemed organization. ഇത്രയും നല്ല ഭംഗിയായി ഇത്രയും ആൾക്കാർ വന്ന് ജോയിൻ ചെയ്ത് ഇങ്ങനെ ഒരു അവസരം എനിക്ക് തന്ന പ്രദീപ് കൊടങ്ങൂറിനും ട്രിവാൻഡ്രം IMA ബ്രാഞ്ചിനും, സെക്രട്ടറി വിജയകൃഷ്ണൻ, സെക്രട്ടറി അൽതാഫ്, പ്രസിഡന്റ് GS വിജയകൃഷ്ണൻ, എല്ലാവരും ഈ അവസരം തന്നതിൽ വളരെയധികം നന്ദിയുണ്ട്. ഇത്രയധികം പ്രൊഫഷണൽസ് അവരെ അഡ്രസ് ചെയ്യാനുള്ള ഒരു അവസരവും ഇത്രയും പ്രധാനപ്പെട്ട ഒരു ടോപ്പിക് ഓസ്റ്റിയോപൊറോസിസ് നമുക്ക് ഈവൻ പബ്ലിക്കിന് മാത്രമല്ല, ഇറ്റ് ഈസ് എ ഇമ്പോർട്ടൻറ്റ് ടോപ്പിക് ടു അവർ സെൽസ് ഓൾസോ. നമ്മുടെ ഹെൽത്തിനെയും ബാധിക്കുന്ന ഒരു ഫീൽഡാണ്. ഇതിനെക്കുറിച്ച് ഒരുപാട് അജ്ഞതകളും ഒരുപാട് അഭ്യൂഹങ്ങളും ധാരാളം അറിവില്ലായ്മയും എല്ലാം കൂടി സമ്മിശ്രമായിട്ടുള്ള ഒരു ബുദ്ധിമുട്ടായിട്ടുള്ള ഒരു സിനറിയാണ് കാണുന്നത്. ഇതിൽ കുറച്ച് കാര്യങ്ങൾ ഒരുപാട് ഇനി പോകാനുണ്ട് ഓസ്റ്റിയോപൊറോസിസ് മാനേജ്മെന്റ് ദൂരത്തിലേക്ക്. എന്നിരുന്നാലും വി ആർ സ്റ്റാർട്ടിങ് ഇൻ ദ റൈറ്റ് സെൻസ്, ഇൻ ദ സെൻസ് ദാറ്റ് വി ഹാവ് സ്റ്റാർട്ടഡ് ദി ജേർണി ടു മാർക്ക് ദി മാനേജ്മെന്റ് ഓഫ് ഓസ്റ്റിയോപൊറോസിസ്. എന്താണ് ഓസ്റ്റിയോപൊറോസിസ് എന്ന് ആദ്യം മനസ്സിലാക്കാം. അത് എന്തുകൊണ്ടാണ് വരുന്നതെന്ന് പറയാം. വാട്ട് ഈസ് ഓസ്റ്റിയോപൊറോസിസ്, വാട്ട് ഈസ് ഇറ്റ്, വേർ ഈസ് ഇറ്റ്, വൈ ഈസ് ഇറ്റ്, നമ്മുടെ ആ ടെക്നിക്കിലോട്ട് നമുക്ക് നോക്കാം. ആ രീതിയിലേക്ക് ഈ ഒരു അവസരം ഏകദേശം ഇപ്പൊ 61 പാർട്ടിസിപ്പൻസ് ഉണ്ട്. ഈ 61 പേരുടെയും ബ്രോഡ്കാസ്റ്റ് ഞാൻ നോക്കുമ്പോൾ ഇറ്റ് മേ ബി ഇൻ ടു another hundreds or thousands. It will go in, my message can go reach a lot of people through you. It is not my personal message, it is a need of the time that even among our doctor community the awareness of orthopedics is not adequate enough, so that it is a generalized disease. Bone matra affect cheyyunna asuvalla, it affects your brain, heart, lung, even vital organs, eyesight, ear function, നമ്മളുടെ മൊബിലിറ്റി, നമ്മളുടെ ദി ഏജിങ്, എജിലിറ്റി, നമ്മളുടെ ഒരു ഓവറോൾ പേഴ്സണാലിറ്റി ബാധിക്കുന്ന ഒരു ജനറൽ ഇതൊരു അസുഖം എന്ന് പറയുന്നത് ഇറ്റ്സ് എ പാർട്ട് ഓഫ് അവർ ഏജിങ് ഓൾസോ. ഹൗ ടു കമ്പാറ്റ് ഇറ്റ്, വി ക്യാൻ ഇൻ ദ നെക്സ്റ്റ് ഹാഫ് ആൻ അവർ ലെറ്റ് മീ അറ്റംപ്റ്റ് മൈ ബെസ്റ്റ് to explain to you what one could understand by what is osteoporosis, why does it come, how can we manage, how can we prevent, how can we treat, and how can we pass the message of not getting the disease, and if at all you get the disease, how to combat it. ആ ഒരു രീതിയിലേക്ക് എല്ലാവരെയും ഞാൻ ഹാർദവമായി ഇൻവൈറ്റ് ചെയ്യുന്നു. ലെറ്റ് മീ, വിത്ത് ഓൾ യുവർ പെർമിഷൻ, ലെറ്റ് മീ ഗോ ഇൻ ടു ദ ടോപ്പിക്. One minute, I'll put my screen on back at the PowerPoint. കാരണം സ്ക്രീൻ കാണാവോ? You can hear me well. You can see the video also.
Kanam sir.
Okay, my name is Dr. Shah Navas. I presently am professor of orthopedics and head of the department at SUT Medical College, Trivandrum, after my retirement from the Trivandrum Medical College as professor of orthopedics itself. So I have been fortunate enough to join a good institution and continue my academics and training postgraduates and undergraduates, which gives a lot of satisfaction to me as a professional. So today's topic, let me present you all what do we understand by osteoporosis and how does it affect you as a professional, as a person, and you can be a patient as well sometimes when you require the treatment to treat osteoporosis by yourself or with the help of colleagues who are very much in the field of treating orthopedics as a personal treatment as well as a public in the public domain as well. So let us understand. We will go by the method of what do you understand by you, and where does it come? Why does it come? When does it come? Who are the persons affected, and why I told you, and how we can combat it about. You are seeing that in this picture there is a picture of a black and white picture of the normal bone, which is much compact. You are seeing white shadows and black shadows. That is a normal bone. When there is no osteoporosis, there's a lot of empty spaces, the loss of the white tissue, which is the bone content, and the bone becomes weaker, and it will go into a lot of fragility. The reason why it is going, we can come to that in the later slides. And the strength of the bone is much reduced. And when the bone strength is reduced, it has a chance to get into mobility and fragility fractures. And fracture is not the essential issue. You will use a lot of vital tissues in the body because bone contains a lot of pluripotent cells, both in its bone marrow. It is giving all the progenitor cells of the WBC, RBC, etc. It contains a lot of strength-giving ions and minerals like calcium, phosphorus, magnesium, all these things are there. So it is a static tissue. The skeleton looks like static. It is not static. It's a dynamic tissue. It is always living, and the living bone is giving away the calcium. It is taking in calcium and phosphorus. It is giving calcium when it is necessary and when it is needed more, and it is the repository of minerals in our body. So in a 10 years time, what is the scenario that has changed in osteoporosis management? Again, you are seeing two pictures on the right side. The top one shows a normal bone lattice in an electromicrograph. The same, when it is affected, you can see the lot of empty spaces. They are not empty, they contain the plasma and the body fluids. And these lattices you are seeing are actually calcium hydroxyapatite and crystalline complex of protein and calcium hydroxyapatite matrix. We will come to that in the nano picture. So what is the epidemiology of osteoporosis, and what is it? Like Dr. Altaf has said, the lifespan of people are increasing because of the modern advances in modern treatment, and people are not getting infectious diseases. They are now prone to communicable disease, non-communicable diseases like diabetic, hypertension, other diseases of aging, osteoarthritis, and osteoporosis, obesity. And all these gets us is a part of our getting increased lifespan and the comforts of modern living. And during osteoporosis, the chance of bone quality comes down. We have a propensity to get a loss of calcium in the bone, calcium hydroxyapatite bone. The bones become weaker, and at the age of say about 60, 70, it is almost half the amount of what you had at the age of 25 to 40, 35. And you have the propensity, even a small fall, upsetting your balance, can crack your bone and cause a very heavy fracture of the lower limbs or the upper limbs, and silent fractures of the spine as well. And what are the strategies available to us to combat this ongoing disease? The osteoporosis does not stop by itself. It is always progressing in our body. How to check that progressing in a very bad way, which will affect our general health? That is what we have to combat. How is it osteoporosis measured? It is generally measured by the dual energy X-ray absorption method. We call it as a DEXA scan. And it is compared with the normal scan of a normal age group at that time of age and build. And it is expressed as a standard deviation from the normal. And that is given as a T-score as well as, excuse me, okay. Okay, sorry for the technical snag. So DEXA is now the standard, the golden, the gold standard value in measuring the bone density, bone mineral density, and we measure deviation. And what is that deviation? I'll be telling in the down slides. Okay. The word meaning of osteoporosis is derived from Greek. Osteo means bone and porous means empty, or it is a porotic bone. And it becomes more common with aging. About 15% of the white race or Caucasians in their 50s and about 70% of those who are 80 are affected. Okay. Thank you. I have my son assisting me in helping me to present this for you. Technical slide. So it advances with age, and about 15% of Caucasian in their age of 50, and about 70% of the above the age are affected. It is more common in women. Definition diagnosis. I said to you, as aging occurs, osteoporosis advancement is going on in our body unless we are doing something to prevent that. And it is more common in the women group because of the female hormones, estrogen. After some time, is stopping abruptly in her body system, and during menopause, her protection of the estrogen is gone. The chances of the female sex getting the osteoporosis, so it is very high. The amount of andropause, we call it as in men, it is an andropause. It happens in a more steadily downward manner. So men are affected a little more in the age group, a little more down, maybe around the ages of 50 to 60s. We are seeing a cut section of the bone, normal side, the bone, so you see very healthy bone matrix made of calcium hydroxide crystals, and they are getting absorbed and they are not put in back, and we get the osteoporotic bone, and you can get fractures of the bone. This is a cut section of the femur. And this normal bone, I told you the standard deviation measure of the bone mineral density in a DEXA scan. One is the cutoff value, which is the normal. Anything below that, around 0, we have the normal density. A standard deviation less than 1 to 2.5 away from the normal for that age is, we call it as osteopenia, means it is a precursor to osteoporosis. After 2 to 2.5, there is the rampant flamboyant osteoporosis happening, more than 2.5 standard deviation of the normal. And this will be the micro texture of the picture in an electronic microscope. We are healing a lot of empty spaces which were filled with bone matrix lattice work of the calcium and phosphorus and proteins, collagen protein type 1. So in the race group, the white people get a lot of osteoporosis more than us Asians. And among the Asians, we are protected by the sun more than any other race because we are living in the tropics. The sun protects us in a very lot way in preventing osteoporosis among our population, unlike the cold countries of Europe and America. Among the ethnicity people, the whites are being affected and the blacks are protected by their skin, which contains a lot of cholecalciferol, which can convert it into vitamin D, which is an essential component of bone metabolism. Comorbidities like diabetes mellitus, hypertension, obesity, they also have a play in producing bad effects of osteoporosis. What is the scenario? Osteoporosis is a chronic, we now call it as a disease. Actually, it is a condition. It is characterized by bone fragility, which is followed by fractures. And like you said, a fracture is defined as a break in the continuity of the bone lamellar structure, preventing a normal function and structure. And when there is a fracture, which may be a silent or an acute episode or a chronic episode or acute episode on a chronic event, the body is affected and the person, he can be out of function. He will be bedridden, needing immediate treatment as fracture fixation, fracture management. And it is a relevant health problem as well. It is increasing in magnitude. In about 50 years, it has increased up to 300% in the women, almost 200% in the men. And in the another next 10 years, it is going to increase more as well. So as a global public health problem, osteoporosis is not recognized in its own merit. We are having a lot of inputs for corona management, hypertension management, diabetes management, but people are not aware. Even our profession, medical profession, is not very much aware of the thing that is the disease process that is happening on the osteoporosis. It weakens the bone, that is the primary structure of our body. And what are the substantial advances in the diagnosis? Because after which all the patient will require treatment, we had to stratify them. People who had to be given mild diet variation exercises, people who need active first line of treatment, who are the people who are requiring more active treatment, and what are the ill effects of osteoporosis that has to manage. So stratification of people according to the diagnosis stages and types of osteoporosis have also been many guidelines have evolved. And we have now more knowledge and instrument to tackle this ongoing osteoporosis crisis. The picture shows the compression fracture of a vertebrae that can happen as a chronic on acute or an acute episode. And in the vague symptoms of backache, backache is one of the largest group of patients we seen by all the people. And we are the orthopedic people will be the person last seeing them. They'll be seen by general practitioners, physicians, the gynec people, even specialty people. So backache is, even though it is not recognized as a big complaint, so much of economic value is there because of the absenteeism that is going on with people getting backache and not attending to their work. And what are the types of osteoporosis? Type means primary, secondary, and we call it as generalized. And this picture I have shown you once before also. A picture of the healthy bone on the right side, and on the left side we have the osteoporotic bone. The same thing in a cross section. The lacunae of empty spaces filled with plasma are more in osteoporotic state, while this compact bone is very much lattice work of the crystal form of bone is there in a normal bone. And what if the primary osteoporosis is mainly said about the postmenopausal osteoporosis in women. The osteoporosis that happens in the female sex when they attain menopause either by natural means or they undergoing a surgery where their ovaries are removed and they have an abrupt stoppage of estrogen protection of the bone, which is taken off. And within 2 years to 3 years of time, they almost lose around 10 to 20% and even about 30% of their bone quality. Secondary osteoporosis is related to our age. It happens to both sexes. And after the age of 60, 70, the osteoporosis sets in our body. And we have the type 2 secondary osteoporosis. And what are the generalized mineralization process which are affected? We have the osteogenesis imperfecta, a congenital disease. And sometimes in children where they have osteomalacia, we call it as idiopathic juvenile osteoporosis. Even when children in their active growth period, if they are not getting enough good diet protective in the calcium and other minerals, they have the chance of being osteoporotic early in their life. So protect your bones when you are young, your children. both male and female, require a lot of compact bone disease nutritional values like calcium, phosphorus, vitamin D, proteins. These are the primary nutritive things that is needed for body growth. And the peak body mass of our body reaches the age of 25 to 30. After that reaches a plateau around another 10 years. And after that plateau of homeostasis of the bone, we start to go down. There is a negative metabolism coming in play. And we have 4 stages of osteoporosis. The first stage, the balance between bone increasing in our body and bone decreasing the body are almost at level. And they are controlled by the 2 types of cell we call as the osteoblasts, which are bone building, and the osteoclasts, which are resorb. They take away the parts of the bone, supply it to the body, like calcium is needed for metabolism of our body. All the cell functions and nerve functions can be required, and nerve calcium is required. Normal value is around 9 to 11 milligram. Phosphorus is another mineral, another ion which we require along with calcium. It is around 4 to 5, and both these products together we call as the ionic index, and it is around 9 into 10 into 40. It will be around 40. The ionic calcium index of our body should be around the range of 40, and if the 40 is maintained, say in about around your age of 40 to 45, you are in a healthy pink state of life. And over the so these are the first 2 stages. There is no balance between the osteoclast function and osteoblast function, and there is a overlay starting around 10 to 20%. The osteoclasts get an upper hand, the stage 2, and there is a normal eating away of the bone by these enzymes secreted by these cells, but you are still strong enough. And during the 3rd stage, that is, the osteoclasts are getting high in their function. You lose around 30% of your bone quality, and during the 4th stage, you will definitely develop a fracture. A fracture of the lower limbs are very, very ill disease state. You are laid up. You need a surgery. Fixation of the bone has to be fixed and supported by implants, and that is you'll have big morbidities at that time, like diabetes, obesity, hypertension, cardiovascular diseases. You may be suffering from any stroke. You'll be taking anti-resorptive drugs. You'll be taking anticoagulant drugs. You'll be taking some anticonvulsant drugs. All these drugs, they have a say in the bone metabolism. And having a lower limb fracture, your life certainly is around, as the age advances, it ranges from 10 to 30% of mortality even. And morbidity is also high. So to prevent a fracture and treat a fracture, there is almost a 300% to 400% difference in management cost. So which is easy. Taking a calcium tablet for lifetime when you are about 60, or preventing a fracture, or getting a fracture treated. This picture of this lady standing tall and erect and very good is a young. As you age, the curves of there will be vertebral fractures. They are the silent fractures that is happening on. The vertebral height will come down. Your height doesn't come down. You will become stooped, and there will be neck. What was the part of the head is now the part of the upper part of the neck, and you will lose a height. And we call it as a stooped. All the females, when you are seeing there, we are stooping. Unless you have a good posture, you cannot maintain a good height and function. Your eyesight will be, you have to erect, and the disease process we call as osteoarthritis, spondylosis, spondyloarthrosis. All this comes in. They have a say in our quality of life as we age. So maximum bone density comes around, I told you, around 30 to 35. And I told you what is what is the definition. Bone mineral density, BMD lower than -2.5, less than the standard deviation WHO has defined as osteoporotic people. a bone peak mass below the unhealthy adults, and it is measured as the strength of the bone. And in some people, the fracture happens even when before you are getting a 2.5 diagnosis, 2.5 ST. So this is not a true cut picture of a diagnosis pattern. We have more advanced diagnostic methods now. So patients who can have a fracture, even when they have a normal bone density for that age group, we missed. So how can we prevent that fracture? We have other patterns we have to get that. The European Union, in the sense that they have a very good repository of data collection, and the population, the European Union, they have the people have a social support from their governments, and they are being given supported by their social support systems, and they have better values of their disease pattern. And in around 500 million people are affected in European Union, and about 310 million in the USA. It is more common, I told you, in women than. And what is the developed world? Even though we don't have a data, we know that about 2 to 8% muscles, they are rough guesstimates, I can say, are affected, and 10 to 38% the female. And the rate of disease increases as age advances. So this is a small picture I got from the what is osteoporosis affecting us as a profession in the daily work caution methods. It's a silent disease. As such, it doesn't produce any symptoms other than tiredness, your lack of energy, lethargy, inertia. All these things amount to loss of function, and your readiness to take up your healthy activities comes down. The picture shows an osteoporotic bone, which it is almost empty of bone matrix, and there is a fracture on this side, which shows an anterior wedge compressive fracture of the junction between the vertebrae of the. It usually happens between a non-mobile vertebral column and a mobile vertebral column, usually the spines D10 to 11 and 12, and in the region of the C1, C7 to 8 also, and L5S1, lumbar 5 vertebrae. So bone fragility come with as a part of your aging. Bone can break due to vertebral. There will be silent vertebral bone fractures in the spine. In the forearm and the hip, the fractures are more loud, and you get more pain, and you are seeking medical attention immediately. And then, a broken bone is the first sign that you have the disease of osteoporosis. Why is it silent? It's a normal part of aging process. I told you there are still 3 to 4 stages, and in stage 3 we have the age group of 45 to 50 by 60. A period of hormonal changes in the body. Females lose a lot of estrogen, and the males lose a lot of testosterone. And other hormone-related are the thyroxine, calcitonin, the parathyroid hormones. All these have a play. And we have the vitamin D. When it was invented, it was in the group of vitamin D. Now it is not a vitamin. It is actually an active part of the hormone. It is called dihydroxycholesterol, and it is very important for metabolism. And this has been mentioned before. Women, the breakdown of occurs at a faster pace in the effects of menopause. There is a reduction of estrogen, they live up to 20% of their bone density, while in the men it happens in a little more advanced age. And they at the age of 60, both the male and female sex, they level out in the disease pattern of osteoporosis. What are the risks having osteoporosis? Some of the risks are modifiable, some are not. What are the non-modifiable risks? Your age, you cannot change. Your ethnicity, you can't change. What is your heredity, you cannot change. So you have to live with that. And what are the modifiable risks? Comorbidities like diabetes, hypertension, rheumatoid arthritis, ankylosing spondylitis, hypogonadism, hypothyroidism, hyperparathyroidism, liver diseases, kidney diseases. All these have a play into bone metabolism. And the primary comorbidity, if it is treated properly, we can manage the osteoporosis better. So they go hand in hand. And hormonal, I told you about the surgical removal of ovaries as a part of disease PCOD in the females. This has to be removed as part of their surgical management. Hypothyroidism, I told you. Chronic kidney disease, GIT disorders like inflammatory bowel diseases, IBS, the irritable bowel syndrome, senility. Then myelodysplastic, as such, there is myelodysplastic disease or the inherited bone diseases, neuromuscular disorders. They all have a play in producing osteoporosis. And what are the potentially modifiable risks? Our lifestyle patterns, amount of alcohol we are using in the daily diets, and abuse of alcohol, tobacco. They have a say in osteoporosis management. The more abuse is done, the more affected you are. Vitamin D deficiency, lack of exposure to the sun, lack of exposure to good diets which contain a lot of vitamin D, mostly the animal foods, like even milk and meat and eggs contain a lot of vitamin D, while the vegetables contain little less. So the vegetarians stand a chance of osteoporosis high. Malnutrition, inactivity. When you are having an inactivity and sedentary habits, poison with metals, using a lot of soft drinks which are containing in the cola element, which is the phosphoric acid, it can produce osteomyelitis again. And I told you what are the causes of an etiology. Bone loss increases after menopause. We have mentioned that. And when it is called andropause, like it is alcoholism, anorexia, hypothyroidism, kidney disease. And what are the signs and symptoms? Where there are very tiredness, body ache, backache, lethargy, anorexia. The graphic picture shows you the balance between two people, the osteoblast and the osteoclast. They are building bones. That this is stage 1 and 2 osteoporosis. And during the osteoporosis stage 3 and 3, the osteoclasts are very active. They destroy the bone mineral wall and the matrix is lost. Aging disease. During old age, what happens to us? As we get older or we get more citizens, we get osteoporosis, osteoarthritis, our joints get creaky, the protective effects of the cartilage which has been inside in our joints lining the synovial joints get worn out, and there is a bone-to-bone contact. And nowadays people are now changing the knees, and we are doing the orthopedicians all over the world are now busy changing joints. Knee arthroplasty has become one of the first line of surgeries in any hospital, like that. And fracture neck of femur as a part of even a trivial fall can produce a fracture. It is said that the fracture first occurs first and the fall comes next, especially around the hip. Vertebral fractures, the anterior wedge compression of the vertebrae. Here you can see it better, and we are fixing it to metal implants, stainless steel or titanium, fixing the bony part with structural supportive systems made up of metal and other metal like alloys. Frailty. What do you understand by frailty? Weaker. It means weak. It's a common geriatric syndrome. The higher the risk, decline of health happens. Old age, you are falling down because your propensity, lack of judging your distances, judging your gait. You fall down. Poor eyesight, poor balances. All these can contribute to the fall. So preventing a fall itself is preventing a fatality. And you need supported walking during your lifetime, during your age process. You have to take the resort of mobility aids. And people living alone, they will be unsupported and they will be taken to treatment even very late. When they take days and days to decide upon a surgical process to be done by their caretakers. Frailty associated with aging, weakness, slowing down, decreased energy, lower activity, unintended weight loss, and even as we get older, we get our thinking process also come down. Start of dementia processes also come. Stage 3, frailty of bones. Reduced bone setting, third stage of the osteoporosis. Stage 4, BMD loss and microfractures. And the bones become spongy and the bone become fragile. We can see it in the X-rays and other imaging modalities. See the normal erect posture when you are young, and you are getting older, you get stooped up, your spine gets bent, and you get a hump in the back. You call it as a dowager hump. Dowager means a widow who has lost her husband in her old age, and the English word is it is called a dowager. So dowager hump it is called because of the C7 and the T1. They become more prominent in the upper part of your chest and the back of neck. Loss of agility in life as we get older, slowing of our gait, loss of balance, poor eyesight, poor hearing abilities. The smallest bones in our body are the ear ossicles. We call it as in the middle ear, malleus, ingus, and stapes. They form a chain from the eardrum to the inner ear, and they are controlled. They are in a fluid medium, and even a small vibration, the sense of balance and hearing, are in the inner ear and the middle ear. During the osteoporotic process, they become thin. This bone becomes thinner, and it is actually, I would say, osteoporosis produces deafness. And even some of my ENT colleagues are now agreeing to that. And they send their patients to orthopaedicians to get osteoporosis managed for better management of hearing defects during old age. Prax, a predictive tool for measuring your chance of getting a fracture. It was developed by University of Sheffield and gives you a value of a 10-year probability of a bone fracture risk. It is measured as a continuum, and you have to get management for that. It integrates the clinical fractures of bone at the femoral neck. Usually when a broken neck, we are standing on our 2 feet, unlike the animal kingdom, which they are walking around on 4 feet. The chances of getting a fracture is almost 10 times more than the animal kingdom. And it calculates the 10-year probability of a hip fracture and the probability you need a treatment. See, as fracture develops slowly, it becomes complete, and there is a total separation of the bone. We divide the fracture according to the level of separation into stage 1, 2, 3, and 4. And during the major 10-year probability is very high, the fracture has to be treated. What is the normal structure of the bone? Bones come in all shapes and sizes in our body. We have around 206 bones, 360 joints, and we are born with around 230 bones. Some of the bones get fused as we get in the adulthood, and bones get joined together. The adult bone contains around 208 bones like that. And the maximum bone density happens in the age of, say, the middle age group of 30 to 35. And this is the compact bone structure. We have an outer very strong called the compact bone, a central area of spongy bone, and in the center, the most inner core area is filled with bone marrow, and that is the microstructure. We'll come to that. Bone strength. The elastic modulus of bone is almost similar to a concrete block in a younger patient, which is about the modulus, only the elastic, but it is 10 times stronger for weight to weight. Normal bone, osteopenia, and severe osteoporosis. And when you compare it to strength of steel, it is having an almost equal strength, but the weight of that bone will be almost 3 times less than the steel compared to the steel to have that same strength. What is the force that is needed to break a bone in a femoral adult bone? That comes to around 4,000 newtons. 1 kilo is around 10 newtons. That means around 400 kg of a violent force is needed to break a normal femur in a healthy adult. And the weakest bone in our body is it is the collarbone, and it also needs around 150 pounds to break it. Our body composition, bones form about 15% of our body weight. In a 70 kilo person, 40% is around water, is a fluid, and it is around 40 kg, muscles form around 30 to 35%, and fat around 15% in a not in an obese, non-obese patient. So how do we forecast the development of osteoporosis in the general population? There was a Chinese study that found that in about 50 years, there is a 100% increase in the proportion of population with osteoporosis. And with obesity and diabetes, it becomes more. And the polluted air also contributes to the osteoporosis phase. The fracture risk comes around to 27% when there is a chance of osteoporosis stage 3 compared to a normal adult of that age group. Measuring fragility, I told you, bone marrow density by DEXA scan. There is a trabecular bone strength we also is measured. Hip axis length is another measure. The length of the hip bone from the outer edge of the femur to the inner edge of the pelvis, that is the hip axis. The longer the hip length, the more the fracture chance you have, the hip fracture. And what is the strength of the analysis? The hip strength analysis by way of X-ray, shadow of the X-ray. There is another measure called finite element analysis. All these are what we call alternate measurements of the measurement of the osteoporosis profile in our body. A newer method, radiofrequency echographic spectrometry. They use ultrasound instead of X-rays. So the amount of radiation you are getting is less, and it is independent of a bone marrow density, bone mineral density. Vertebral and humeral, vertebral fractures and non-vertebral fractures. We have the hip fractures and the non-hip fractures. 50% of the people with one will have another fracture in 2 years' time. And most of them have to be supported in their whole of their life, and about 30% require full deficit treatment. Mortality is around 20 to 25% for any hip fracture. And half the patient, more than half the patient requires supported life patterns for the rest of their lives. Coming to the microstructure of the bone, how much of hydroxy, calcium hydroxyapatite phosphate crystal is around 60%. And the other protein complex, we have the type 1 collagen and the calcium, they form the microfiber. These are bone and this is the compact bone. They are arranged in osteon. The osteons are forming microfiber, and the microfibers are arranged in helices of the collagen spirals. It is a triple, we'll come to that. It is a triple helix arranged in a pattern where the calcium is there. These calciums are not permanent there. It's taken out and put back. That is why the ionic calcium, we call it the calcium ionic pool, calcium pool in our body. The labile calcium pool in our body is in the bone. Nanostructure of the bone. These green units are the calcium hydroxyapatite, and these are the collagen fibers, and they are arranged in helices. And this calcium is taken away, the fragility of the bone increases, and it can break. The strength is by this. These are needles, just like needles, protecting these fibers from, just like a spiral rope that is being twisted, and in one and one fibrils, it gets more strong. The more number of fibrils they have, the stronger is the bone. Nanostructure, I told you, this is a nanostructure of the bone, collagen motif forming a triple helix, and that triple helix will be formed into 5 triple helix will be get into microfiber. That microfiber will get converted into osteons, and the osteons are getting into Haversian canals, and we have the tubular bone, long bones of our body. Nanostructure, I told you, there is a period. It is they are arranged in a staggered pattern, not straight. See, this will be they are arranged in a staggered pattern. We call it as a quarter stagger. There is a repeating periodicity, and these are the calcium phosphorus ions, and these are the collagen part. Microstructure, I told you, calcium is critical in a multiple cell functions, and it is a labile pool. Along with the mechanical role of the bone, we have the reservoir of calcium homeostasis happening in the body. Vitamin D, it is not a vitamin, it is a hormone, and it is a predictor of low bone quality. Serum normal value is around 80 to 80 nanomoles per liter. Recommended daily dose is around 800 to 1000 international units. Very high role in osteoporosis prevention. What are the normal sources where we vitamin D? Milk, sunlight, eggs, mushrooms, meat, liver, and the animal parts, cheese, then fish, cereals. They all contain vitamin D in large amounts. Assessing the burden of illness in the Europe, they have the scope called the Scorecard for Osteoporosis Prevention in Europe, and they have established a 10-year study and it's running in 29 countries. They measure the burden and estimate future projections needed. They forecast the population that are going affected and how they can be treated. Say, they have 37 billion people in 2010, and it has increased to 57 billion people in 10 years' time. And it is only the direct cost. The indirect cost they have not calculated. And they are screened by screening strategies, by the DEXA scans. So this gives it is a scope picture giving you the vital statistics of osteoporosis management. 32 million people affected in 18. The people affected in the age group of plus 50 is, in the males it is 6.6, the female it is 22.2. And the cost that is around almost 57 million. Increase of the treatment gap around 55, only 55% in the 2010, it increased to 70% in 2019. And then how many people in millions it is increasing. Fragility from 5.3, and with the adequate treatment, they have even reduced it to 4 million. 4 domains covered. So burden of illness, policy management, etc. HRP-QCT is a high-resolution peripheral quantitative computed tomography. It is based on not X-ray, in X-ray technology, but the amount of radiation is much low. This is the machine. The person is putting the foot inside and measuring the amount of calcium and hydroxyapatite crystal lattice formation in your heel bones. But it is now a little on the expensive side. And in course of time, it will be more used because it is very easy to measure. And the propagating fracture as of now, the cost it is expensive. And now the biomarkers are being marked for how to measure osteoporosis. MicroRNA is being studied. It is because of the lot of microbes in our body, and most osteoporosis is measured by the amount of microRNA coding is measured, and it gives you a value. This has not become practical in daily management affairs because it is an animal study only. In due course, it will become in the clinical side of management itself. So summarizing the precision medicine, what are the novel markers of bone fragilities like bone score, in the management of bone quality in the female, in the bone in X-rays, the high-resolution PQCT management studies, early diagnosis of osteoporosis can be done, and it can target the right population, the right time, and the right patient group. And precision gives you, precision medicine we call that, really highly sensitive specific diagnostic it gives. And with due course, we can have novel analytical methods we can have. And in the scope method, they have formed a fracture liaison services all over their hospitals in treating old age and sensitive fractures. And they identify the disease, investigate and initiate the therapy, and they have succeeded in reducing the incidence of new fractures. Fragility fracture management has been, treatment is taken, and more modalities and guidelines are developed from them. We are also following many of their guidelines. Secondary prevention, how to prevent the second fracture. Fracture means reduction in the population level. And the risk is especially very high, 2 years following this fracture. What is happening to our country? We have in India, we have the RSP with Rashtriya Swasthya Bima Yojana by the government of India. In Kerala, we have the Kerala Arogya Suraksha Paddhati, our program. And we, the retired people, we have the Medicare. The government is giving a lot of protection for the senior population. And now all the hospitals are getting protection of the older people because they are covered by the social support by all these 3 modalities of social support from the government agencies. And even including my department. We are treating a lot of aged fractures. People, they are getting almost treatment. They come in, cashless entry, get the treatment. They are even going away with good treatment. And because it is an expensive procedure, the family people are also very happy to bring their aged mother, father, or relatives and getting the treatment for this. So all this has revolutionized in our own setup the treatment of osteoporotic fractures and fragility fractures in our scenario. International Orthopaedic Osteoporosis Foundation, it is a long 10-year-old project. They have advised this fracture liaison progress around 49 countries. And in the American Society, they have also developed these fracture liaison services in all the hospitals under them. They come under the social protection schemes of each government. And we are also not far from adopting these methods. Fracture liaison services are much more seen in orthopedics across all the hospitals in our state. Future perspectives: how to prevent osteoporosis, reduces the risk fracture. This picture is the broken handle of the osteoporosis clinic. It is not the picture. I just wanted you to on the lighter side of life. So what is the pharmacological treatment for osteoporosis? It began 70 years back. Estrogens were the first modalities of treatment at that time. And in the 70s, we had the bisphosphonate. It is a compound which is similar to the osteo. It reduces the amount of bone being absorbed from the body. It prevents the osteoclast actually. Bone resorption is reduced with the bisphosphonate. We have a lot of bisphosphonate available, I will tell you shortly. And most commonly worldwide, this is one of the first line treatments. Alendronate is an oral drug. Ibandronate is also an oral drug. Zoledronic acid is a intravenous drug. Risendronate also is a simulator of the serotonin uptake. Also, the raloxifene is a serotonin uptake drug. Calcitonnin, which was used as a nasal spray as well as a subcutaneous injection, which helped a lot of preventing vertebral fractures, not the limb fractures. Other newer drugs is one of the newer drugs is the denosumab, which is a potent it is given as an injection called Prolia. It is given as a subcutaneous injection of potent. It is given at least once or 2 times a year. You have to give only. It prevents the osteoclast from functioning. And there are so many good things and bad things about it. This small presentation, I cannot give you all that in a short presentation. And there are the anabolic, another group of medications called the teriparatide and the abaloparatide, a newer medication. And there are combinations of, it can be both anabolic and anti-resorptive also, which is called the Romo. It is not widely available now. So we follow a sequential, combined, and sustained approach for management of osteoporosis. So the whole, what you are in your bone strength, that is your personality. And management of an old age fracture comes at priority because they have these senior citizens have given a lot to the production of uptake of the society when they were younger. So it is our duty and legacy to protect them also when they are beyond the non-productive side, what we say as elderly population. Natural aging, you have to be active. And sunshine, water, wind, movement. When you are active, life makes you pleasant. Absence of one will make you lose the other. When you are not in the sun, you are taking adequate hydration, not getting exposed to wind and air, you get more senile, your skin is affected, and these activities, outdoor activities in the old age are better. Okay. Prophylactic surgery, we have surgery, we are putting implants like stents inside of diseased arteries in the veins when they are affected in the cardiovascular diseases. But nobody will come and put a implant in an unbroken bone because to prevent a fracture that will be going to happen in 2 years' time. That will be coming maybe in the future. And there are some drugs which are some medication that can be injected into the bone, let's say exactly into the femur neck or into the vertebrae. It contains it contains minerals which are osteoconductive calcium-based material. They are incorporated into giving mechanical benefit for that part of the bone. So local osteo-enhancement procedure is happening in the spine and the hip now, and they are also very expensive type of treatment. Let me conclude a little longer than I had expected. Osteoporosis is protected to cause millions of deaths worldwide. We had to prevent that. And to face this anticipated crisis of this epidemic, we have to develop and get aware of these diagnostic and prognostic therapeutic strategies. Osteoporosis is a part, it will not go away from our society, it is there, but we have to reduce its sting and bite of the population. And we are developing combined and sequential strategies, and with advancement of knowledge, we will be getting more innovative pharmacological therapies. I had a few references. So build your strategies in combating osteoporosis as a person, as a public health professional, as a good doctor, as a person per se. My take-home message, humbly I would say, is you have to love your bones because they have to carry you your whole life, and they shall carry you a long, long way. In our own culture, we have the Panchabhutams called the water, earth, agasha, vayu, and fire. If you take the fire and agasha together, that is the part of the sun. The sun gives you a lot of light and fire and heat. And the air is around us, water is around us, the earth is holding you. We are allowed to walk on the earth because of our lower limbs and upper limb and skeletal structure. So love your bones, take care of that, and it will take care of you. Thank you. Thank you for your kind attention. I'm very glad that you have given me the chance to attend to present this program to all of you. Thank you.
Hello. And before going for discussion, I request our AMS Kerala State Chairman, Dr. R.C. Srikumar, is here. I request Dr. R.C. Srikumar to say a few words. Hello? Hello? Dr. R.C. Srikumar? Hello?
Hello, Pranjolu.
Dr. R.C. Srikumar?
RC line
Dr. Anand, I invite Dr. Anand for conducting the discussion. Dr. Anand.
Yes, hi. Thank you. Thank you, Shah Navas, sir, for that very exhaustive coverage of osteoporosis. You've covered the basics and the advanced assessment, modality, treatment, and everything. Over to the audience. If you have any questions, please, you can either put it in the chat box or you can unmute yourself and ask the question as well. I have a question to Shah Navas, sir. Can you give us a basic idea of at what age we should start screening, and depending on the C-score of osteoporosis or osteopenia, what kind of early interventions in terms of therapeutic interventions can be offered to the aging?
That's a good question, because now the BMD is measured by your DEXA scan. It is a little costly now. You will be charged around 900 to 1,000 rupees for a DEXA scan. It measures your bone strength and gives you a standard deviation value of how much is your bone weaker when compared to a normal individual of that age or a younger individual. That is a T-score and a Z score. If that is around -2 to 2.5 or even less, you have this osteopenia. You can measure from a range of osteopenia to osteoporosis and advanced osteoporosis also. If the value is high, which is more than 2.5, that person requires a highly protective therapy to prevent an osteoporotic fracture in a later life. So we support that DEXA scan with other measurements like vitamin D calculation, vitamin D level in the serum. Normal level of serum will be around 40 to 60 or less than. Above between 24 to 40 it is a deficient, and below 20 it is highly deficient, and more than 70 we call it as a toxic weight, which we don't see much. So vitamin D level is also give you a measurement of your bone density matter. And now, because now it is being practiced now, I am finding a lot of patients, young patients with values around 20 who complain of backache for a long time. And the vitamin D is so low because our exposure to sun and is very much low now. Previously, we used to be in the lot of the sun. We have now our private cars, our AC rooms. We don't go into the sun at all. So when you don't love the sun cannot give you enough exposure. The ultraviolet rays of the sun react with our skin, and it gives you a metabolism of hydroxylation of one of the calciferols, and that is taken to the liver for the second hydroxylation. And another hydroxylation 1 and 2 happens in the liver and the kidney, and we have the active molecule of the dihydrocholecalciferol. And that is one of the primary elements in bone blast, osteoblast function. So when vitamin D is less, this quality of bone protection is lost. So that person requires when the DEXA scan is low, vitamin D is low, or when we call as the bone chemistry, the calcium, phosphorus, proteins, when they are in the lower side of normality, it is what we call it total treatment, or what we call as a pan side of treatment. They require all that: good nutrition, a good exposure to sun and activities, a good amount of calcium and vitamin D intake, good nutrition to take proteins, and natural courses. They should be supplemented. Now we are giving vitamin D being a molecule which is fat soluble. You don't have to take it daily. You can take it once in a week or once in a month till you get an adequate level stored in the liver. And calcium being highly lipid, you have to take it daily. And the amount of calcium we need in our growing phase of children and pregnancy state of women, they require a lot of calcium extra to build up their bones. And we reach a maximum of peak bone mass around our middle age, say 30 to 35. After that, we start losing. And to prevent that loss, we have to get adequate dietary supplements. So once you know that osteoporosis is a thing we have to live with, you should take adequate steps. Instead of treating a fracture, I would be happy to treat a person to not prevent that fracture. Not all fractures can be prevented. Some of the fractures maybe not osteoporotic alone. Even a trivial fall can produce a fracture. That is a fragility fracture. So I hope that, so your patient, when you are suspecting a bone fragility, you would ask her to get all these tested. Bone scan, vitamin D, bone mineral proteins like a bone chemistry. And you also examine their kidney status, see that most of the drugs you are going to give, these bisphosphonates, have a say in the renal function. And we have to be highly protective if then the GFR, the glomerular filtration rate is much less in there is a kidney disease also, and in diabetic also.
Sir, sorry, wait a minute. Dr. Ashish Kumar has joined. So
he is joined.
So, yeah. Dr. Ashish Kumar, our AMS state chairman. So I invite him to say a few words.
Sir, ഞാൻ നേരത്തെ ഉണ്ടായിരുന്നു, വിളിച്ചപ്പോൾ കേട്ടല്ലോ, ഞാൻ കേട്ടോണ്ടിരിക്കുകയായിരുന്നു. ഷാനവാസ് സാറിന്റെ സെയിം ഒരു സിമ്പിൾ ആയിട്ടുള്ള ഒരു ടോക്കും വളരെ ഇൻഫോർമേറ്റീവ് ആയിട്ടുള്ള. ഷാനവാസ് is always very simple. It was a very excellent mode of presentation. Congratulations. And this is something which we never address into it, because if you see that old age doctors, many of them have fractured femur or something like that, and many of them die of this also. Sir, is it and many of them develop major complications of when doing surgery, and So do you advise surgery for the correction, or do you advise conservative, for example, osteoporotic fracture, etc.?
Fractures of osteoporosis,
You advise
conservative treatment is not a good theme, in the sense that fractures very God, even the calcium is taken away. Union of that fractures is very remote. So we have to give supportive treatment for that fractures. Even the highest old, we could treat people who are 102 years old with fractures. And they had a good quality of life after fracture management is very almost, they reach almost the pre-injury level. So treating fractures, especially of the lower limbs and the upper limbs, we have to go in a very, what we call as a very energetic way, aggressive way.
Thank you, sir. And I also congratulate the AMS team, Pradeep sir and Anand, for the excellent the go ahead. So once again, all the best. Thank you.
Thank you, Srimar.
Thank you, Srinivas sir. There is one audience question from Dr. Shabir. It is about osteoporosis care gap.
What do you understand by osteocare gap? That is this question.
Yes.
Yes, it's a very relevant question. Number of people with an osteoporosis coming to you, there is almost 10 times not coming to you in the society. So there is a big gap between your diagnosis and treatment and the necessary requirement treatment are in the society. That is where the social public health care people have come out with programs like FRAX, where they will go out into the society and measure the amount of bone mineral density among the public and bring them to the limelight to get treatment. So this gap between the care of the osteoporosis, which is the tip of an iceberg we see, and in the gap as a public health phenomenon. Now, we can take an example of the iodized salt. We did not give an iodine. There was no iodized salt before that. There was a salt anyway, iodine also there. When the government of India now brought it, that only iodized salts, the amount of hypothyroidism came down. And we have social structures like that. There will come a stage when the government will be given some calcium tablets in the public health system like that. So osteoporosis care gap is very high. The huge gap, even in European countries, it is very high. And the amount of the care treatment there, it is a costly treatment. Getting a fracture treated in an old age person, because they will have comorbidities like hypertension, heart diseases, lung diseases, people taking multiple drugs like steroids, anticonvulsants, hypertensives with the resorption of the bone. And there the amount of calcium, the osteoporosis, medical induced also. So assessment of a person is not osteoporosis alone. The non-osteoporotic body elements have to be checked also. How much they will withstand the treatment of osteoporosis by conservative treatment, assisted treatment by the medications, and ambulatory treatment required by the surgical treatment. So it is an overall projection of that person is required.
Thank you. It's 9:30. We'll take one last question. It is about the ideal age to start screening for osteoporosis and how often should we do it?
The ideal age to be patients after menopause in the female. They should be taking enough vitamin D and calcium and other minerals, magnesium, and in their daily routine. Until you are around 45 to 60. And after the 60 that you have to cover a gap of almost 10 years of non-treatment. So that is where we have to fill up the gap. The gap, sometimes we are able to fill up, not that necessarily. So the ideal age, it is less like you are taking anybody, aspirin and droplet we are taking to prevent a blood clot. Just like that, we have to start taking anti-resorptics like calcium, vitamin D, and sometimes alendronate also, bisphosphonate also, along with our combating daily management of osteoporosis in preventing fractures.
Thank you, sir. If there are no other questions, it's 9:30. We will come to the conclusion of today's session.
Very kind of you.
Yeah, I'll specifically thank Shah Navas sir for that exhaustive coverage and going into the depth of the topic. Congratulations to Pradeep sir once again for another successful AMS program. Thanks to Jason sir, Dr. Altaf, and C. Srikumar sir for joining us and sharing your thoughts. Thank you all. Please do continue to check the WhatsApp group for the upcoming sessions by AMS. Particularly Pradeep sir is putting a lot of effort and enthusiasm in trying to bring the best of the best from Trivandrum and around in terms of possible academics, which you can sit at your home, relax in the evening and listen to. So looking forward to seeing you all again at the next meeting. Thank you. Pradeep sir, if you have any announcements about the upcoming activities.
Yeah, we have the World Cancer Day on February 4th, and that weekend is going to be a Maha weekend as far as AMS chapter is concerned. We have a cyclathon in the morning, 4th morning, and we have an CME in the evening, and on 5th we have a radiology workshop. So that'll be a busy weekend, and invite all of you to participate in that. Thank you.
Thank you all, and good night.
Thank you, Dr. Pradeep. Thank you.
Thank you, sir. സാറിനെ ഇനിയും വിളിക്കും. ഞങ്ങളുടെ ഇത് തന്നെ ഒരു സെഷൻ കൂടെ ഞങ്ങൾ വിളിക്കും.
എല്ലാവർക്കും അപ്രീസിയേഷൻ ഉണ്ടെന്ന് വിചാരിക്കുന്നു.
ഓ, താങ്ക് യു. സാറിനെ വെറുതെ വിടുക. ഞങ്ങളുടെ ടെലിവൃത്തിന് സാറിനെ ഒരു സെഷൻ കൂടെ ഞങ്ങൾ വിളിക്കും.